Welcome to this Vital Health podcast. I'm Duane Schulthess, the CEO of Vital Transformation. My guest today is Melanie Whittington, Managing Director and Head of the Leerink Center for Pharmacoeconomics. She is also a Senior Fellow in the Center for the Evaluation of Value and Risk in Health at Tufts Medical Center. Mel, it's always great to see you. How are you doing?
Great to see you. I'm happy to be here.
We've always had a good conversation, and I'm looking forward to our chat today. So you lead the Leerink Center for Pharmacoeconomics. One of your many roles is to develop cost-effective analysis, both in the development and approval of medicines. And from a societal perspective, can you explain what exactly that means, please?
Yeah, so first, kind of what is the Leerink Center for Pharmacoeconomics? The Leerink Center for Pharmacoeconomics is a division of Medicorp. So Medicorp has existed for 30 years, and it's kind of like a think tank intended to provide information on the strategic direction and perspective on the evolution of healthcare. This is not new news to you, Duane. Prices and price scrutiny we're continuing to see evolve in the U.S. landscape. And so that's what the Center for Pharmacoeconomics is supposed to do. It's more of a think tank that is affiliated with Leerink Partners, but is not part of Leerink Partners. It is to bring some health economic principles into drug development, healthcare investing, but also to bring information about the incentives for innovation. What do we need to keep getting more drugs out into the world? So what is it that we do? This is where I think it gets kind of exciting. I use health economic modeling to talk about the impacts of innovation. You know, a lot of the conversations that are happening in drug development and even in commercialized drugs is about profits or potential profits. And that's very important. You know, this is a business that requires those things. But the ultimate buyer of drugs that happen to get commercialized, they don't really care about profits or potential profits. They care about impacts. Their returns are not measured in profits. They're measured in, hey, if we're paying for this drug, what are we getting for our health and for cost efficiency in the health system and in society? What we are trying to do is talk about the impacts of innovation. We're trying to broaden the application of cost effectiveness analysis and say, listen, you can use this as a storytelling tool and look at, hey, here's my potential phase 3 outcome. What does this actually mean for patients, for the health system, for society? And can investors use health economic modeling to say, you know, this is the market-based price that I'm expecting based on market analogs. Is the public going to think that this price is worth it, or are they going to think they're being price gouged?
I think one of the criticisms about HTA value-based assessments, qualities, is it's an academic exercise often devoid from the market and market forces.
100%.
It lives in sort of isolation, like in this hermetically sealed jar somewhere off on the distance. Working closely with Leerink Partners on the investment side, the broker-dealer side, you come out of academia. Has that informed your decisions? I mean, has this perspective broadened a bit, Mel?
Oh my gosh, so much so, Duane. So I very much acknowledge when I'm building a model, I am living in a hypothetical world. Now, how can we make these hypothetical models a little bit more real world? Well, we talk to stakeholders. We learn what is necessary for innovation to continue. Now, this isn't to say modeling the hypothetical world isn't important. Can it still provide important evidence? Yes. I look at drugs completely differently now. I was just at the Leerink Partners Global Healthcare Conference, and these conferences, you have, all of these different companies presenting about their companies in all these different rooms, and you're able to listen and hear what they're working on and see what phase of development that they're in. You hear okay, there's multiple companies working on the same condition at different phases of development, and not all of them may get approved. And then, okay, if it does happen to get approved, now you have this ticking time clock for when generics could come in or biosimilars could come in, or, there's already a competitor in the market. And so how is it going to differentiate, and what's going to happen when that competitor has generics coming in or biosimilars coming in? Innovators and investors have a time-limited period of time to attempt to generate a return. And then patents expire. And the market design is set up for long-term efficiency and long-term affordability, but it takes a long-term horizon and it takes consideration of those market dynamics. And so that is something that our models, our cost effectiveness analyses can consider. Is it, instead of thinking about here's my price at launch, well, what's going to happen in 14 years? And so in conventional cost effectiveness analysis, those price dynamics are not considered. I was modeling something for multiple sclerosis earlier this week, and it's okay. I'm starting my model at average individual is 38. My model goes until they're 100, so it's 62 years. Conventional approaches would hold that, hey, if these DMTs for multiple sclerosis are in the like $80,000, they would hold that constant for 62 years.
Yeah.
No investor or innovator is expecting it, to have that high for 62 years. And we can look at the market of disease-modifying therapies for multiple sclerosis, and they've been very successful in generics rapidly coming in and steeply dropping down the price. And so you can incorporate those dynamics into modeling. My real hope from being affiliated with Leerink Partners and being able to engage with investors and innovators is thinking about how can I adapt health economic modeling to promote efficiency, because that's important, but to also make sure we have adequate incentives for innovation and we can tailor it in a way to be able to achieve both.
There's a belief that just because you get a patent and just because you get an approval, once you get this FDA or EMA approval, suddenly it's this magic license to print money. And all I can say is, look at PCSK9 treatments for cardiovascular treatments. Again, really good drugs, great gene therapies, monoclonal antibodies, fantastic stuff. But Lipitor went generic 6 months before the damn things were approved. The market just vanished. It's like just because you get an approval doesn't mean you're going to be successful. And the other problem with theoretical models, and this is an old joke that Harry Bowen, my economist, and I will often tell to each other. There's two economists and they're shipwrecked and they're on a desert island, and the one economist looks at the other economist and says, okay, imagine we have a boat, This is the problem. I mean, theoretical constructs are exactly that because they don't have market dynamics and market forces. Aside from debates we've had around quality and cost effectiveness, et cetera, and my belief has always been the market decides. What we're having now, analogous to what we're seeing in Europe, is the government is starting to step in and say, okay, we are going to take over this market. We are the largest buyer, approximately 60%, depending on your indication class. We're going to start setting prices. MFN certainly came into play now. This is in discussion. We've had an executive order. They're trying to push for legislation. We've had IRA. I remember going back, we had HR 3 proposed by Nancy Pelosi. Before that, we had International Pricing Initiative, IPI, going back to 2016 with Secretary Azar in the first Trump administration. The government is putting its foot down. What is your opinion now of some of these pricing models which operate in many ways completely outside of cost effectiveness?
I try not to react to a specific policy or a proposal, but more look at the underlying trend and think about okay, what is the sentiment and how did we get here? And so I think what IRA and MFN and all of the other things you just talked about tells me two things. One, the vast majority of the world is unaware of what it takes to bring a drug to market. They are unaware of the private capital and the amount of risk that it takes, the failures. I think they're also unaware that drug prices are intended to be high. The price is intended to be high to be like, oh, hey, innovators and investors, you want this, work really hard, risk your capital, and have the reward be so big for the rare few that get approved, let alone those that eventually become commercial successes, that it incentivizes the investment and the risk for all of the ones that will not get that reward. I think we should all look inward and be like, well, why? Are we doing a good enough job talking about that? Are we doing a good enough job celebrating hey, generics entered for Entresto and the price dropped 99% overnight? Who is educating people that drug prices are intended to be high for a period of time and then they're intended to fall off a cliff? The second thing these policies tell me is that the market-based pricing approach to drug pricing in the U.S. is being questioned. And this essentially means that the market-based prices for prescription drugs in the United States are being seen as not worth it. And so I agree with you, the market should make the determination. But how do we use evidence to inform those market-based conversations and negotiations of actually, this is the price and this is why it should be seen as worth it. And that why it's worth it piece, I don't think is done as much or as loudly or as publicly as it probably needs to be to help the public understand if and how the U.S. drug prices are worth it.
Yeah, the problem you're going to see, and what we at our firm have been predicting now for 2.5, 3 years, particularly with the Inflation Reduction Act. We were saying, look, if you implement this, 54% of all current approvals are small molecule, and most of them are in oncology. You will see a drop in oncology products. If you start just blindly attacking these prices, the first place you're going to see this is in cancer, primarily small molecules. Now, we're about to release a study If you look at all secondary studies using that point of lead asset approval and look forward, we're seeing a 37% drop in oncology small molecules. What's really interesting, Mel, we're seeing a 27% drop in lead assets in small molecule oncology. Now that's phase 2B. So that means companies are saying, okay, we're washing our hands on this, we're walking away. That means people are willing to take a bite and walk away from a sunk cost, which you very rarely see. That means they're making more money and they're going to do better on their bet by pivoting away from an asset that they were going to potentially bring to market. Are you surprised that we are seeing these quite steep, statistically significant drops?
Sadly, I'm not surprised. Our mutual friend, Dr. Steve Potts, he had a congressional testimony, 3 years ago saying hey, this is going to happen. It all goes back to bringing a drug to market as a business. And so these are rational business making decisions. And so am I surprised? No. Am I saddened? Absolutely. I remember when I listened to Dr. Steve Potts' congressional testimony, I think it was in 2023. One of the examples he laid out was for glioblastoma. I was very fortunate in 2023 to know very little about glioblastoma. Probably best treated with a small molecule, and it's a population of around 65 and older. And so this was kind of a target for some of the things potentially in the Inflation Reduction Act. Sadly, a year later, my mother-in-law was diagnosed with glioblastoma.
I'm sorry to hear that.
You start looking at where are the safe and effective treatments? And oh my goodness, there is not much. I think I read a press article about it calling it a clinical wasteland. And then it's why isn't there innovation? It's a really hard clinical condition to treat. And so there's already clinical roadblocks. But then you hear about in this testimony in 2023, well, now we actually have policy roadblocks too, because it's probably best treated with a small molecule. And it's largely a Medicare-eligible population. And so now we not only have the clinical roadblocks, but we also have the policy roadblocks.
The reality is, I look at my father. My father's dealing with stage 4 prostate cancer right now, and he's being kept alive with an Xtandi-type product. That's the reality. By circumstance, we've done a lot of work on intellectual property around Xtandi and some of the Bayh-Dole attacks around Marchand rights. It's you can't do this. And yes, Xtandi is the only drug we find currently that's a blockbuster where all the patents come from the government. That's the only one from 365 drugs we analyzed. One of the problems, I think, Mel, is that people don't understand that it's really just a very precious few drugs that are actually funding the entire ecosystem. Literally, by the time you model down 25 drugs, okay, we're going to reduce the price of these by 50%. You've literally hit 35-40% of the entire profitability of the market. It's sort of what Hollywood devolved into in the aughts and teens, where you'd have a blockbuster, a $2 billion blockbuster that was funding 50, 60 other films in development. And that's the model. And so when politicians say, okay, well, we're only going to hit these 10 drugs, it's no, you don't understand.
Those are
Yes.
This is what's keeping things going. Yes.
Yeah. What do we do about that? We are seeing now a 1/3 drop in oncology. We are seeing this. Do you think the general public gets hip to this? It's wait a minute, someone has an untreatable cancer or a cancer that's very virulent. Suddenly they're aware, wait a minute, we're actually disincentivizing oncology. Do you think there's a blowback there finally that people are going to wake up?
Duane, I want to say yes. The world is not seeing the U.S. market-based prices as worth it. Until we address that, I'm nervous we won't see action. Lower prices are good, but what trade-offs am I willing to accept for that? Until we start showing, hey, this is what a drug can do. This is the returns we're getting to the health system, the returns we're getting to patients. And the price is intended to fall off a cliff in 14 years and be very, very cheap. Until we start educating people about that, I don't know what we're going to get.
One of the other things I think that was so interesting about the debate, particularly around the Inflation Reduction Act and invariably what we're going to see around MFN, and those of us who are doing the work are saying, hey, you're going to see a lot of drugs come out of Medicare. Meanwhile, you have very good PhD economists who I have a lot of respect for saying, oh, you're only going to lose one drug every 10 years. Empirically, you can't cut profitability by 50% and only lose one thing. It's no, you're going to affect the entire market space. Why do you think the academic side of this debate got it so wrong?
Look, I'm a modeler. I love building economic models. I love thinking that, hey, my model can synthesize all this important information and extrapolate. But to what we talked about just a few minutes ago, models are a hypothetical world. In a model, you assign a probability of something. But in the real world, these could be go or no-go decisions or yes-no decisions. It's not some probability. It's, hey, this area seems like there's a lot of uncertainty here. Seems like there's some extra potential roadblocks. Or there's this area that doesn't have as much uncertainty and fewer roadblocks. And so I think it's hard in models to capture those like go, no go, yes, no decisions. The real world is not some perfectly crafted probability model and mathematical formulas.
Do you think a lot of it has to do with the fact that we've been focused on macroeconomics and elasticities at the market mean, as opposed to micro firm level decisions, asset by asset? You know, when I was in Jody Arrington's panel with Director General Swagel from the CBO, one of the things I actually pushed him on, and he actually admitted it in this committee meeting, was, oh yeah, we didn't model at the indication level. Wait a minute, you just looked in the aggregate? You didn't look at decision by decision? You know, and I think at our firm, we're micro operators. We really look at firm level decisions. We look at asset by asset impacts. We do look at those individual go, no go investment decisions at the asset level. Now that's hard. And I get that. But that's how investors look at this. Do we need to bring more of that into the face of what we're trying to do here to get a better modeling, I guess?
Hearing from investors, hearing from companies, and then trusting what they're saying about what the incentives for investment are essential. I think for the investor audience, for the company audience, for the people who could be profiting off of fewer restrictions, how do we still make them seen as trusted and having an enormous amount of very positive feedback that we need to incorporate? And they're actually, you know, very much telling the truth, and they should be listened to and respected.
I think the rhetoric has gotten so heated, particularly post-COVID. You know, I understand it's really fun to tear down things and throw Molotov cocktails. I get it. But you're potentially destroying an entire sector here. And it seems like we're doing so for political expedience because it's popular. And my concern is if we look at the rise of China and what we're seeing, this one order of magnitude of increase in clinical trials being filed with FDA by Chinese companies between 2018 and 2024. Chinese companies now are filing more FDA trials than European companies are. Is it salvageable from where you're sitting? I mean, is the reputational side so jaundiced now that there's no way of getting it back? What do you reckon?
No, I think it's absolutely salvageable. I think everybody, the first thing that happens when you or a loved one gets sick, it's, well, what treatment is there for that individual? And because I think that is universally held by people, it is salvageable, absolutely. It's something that everybody wants, and that's a good thing. I still go back to like the underlying issue. What is driving this? The just, general public, when they think of a prescription drug, they think of the direct-to-consumer ads on television. They think of the commercial successes that are priced high. Remember, they're intended to be priced high. And they think of, reading the news and hearing executive CEO salaries. And so they think that the prices can be much lower. We need to change the conversation, and we need to start talking about what it takes to get a drug to market, that it requires private capital and risk. Nobody has to invest in biotech. They can take their money and invest in tech or other sectors that have better returns or less uncertainty. Like, the returns have to be comparable, or we're not going to get innovation or investment. It's okay to be talking about profit, and we have to tell people why that is important. Branded drugs can be seen as expensive. This is a budget buster. We need to contain this cost. Or you can see branded drugs as an investment vehicle, a solution for, hey, in 14 years, we're going to get the returns from this drug, returns measured as health outcomes and health system efficiencies. We're going to get those same returns, but by this time, in 14 years, we're going to have generics enter or biosimilars enter, and it's going to be much cheaper. And then that is how we get health system affordability and efficiency. It's not a 1-year time horizon. It's not a 4-year time horizon. This is, 14, 20-year time horizon that we need to be thinking on. And so I think it's salvageable, but I do think we need to be having a different conversation.
I remember all the heat around Sovaldi in 2013, 2014. Now it's free. It's essentially free. I had a conversation with Amitabh Chandra a couple of years ago in Switzerland when we were at a conference together, and he pointed out, look, if you're a Martian on Mars and you get hepatitis C, you will be taking Sovaldi, 100 years in the future. It was a really good point, because the point is the thing is free now, and that is a very super effective drug, and we're about to eradicate hepatitis C from the planet. What's the long-term societal benefit of that? It's infinite. And the small amount you paid up front is going to disappear. Plus, the alternative treatment, pegylated interferon, which was the alternate pathway, was half as effective and in real terms was more expensive than Sovaldi by the time you looked at the cost per cure. This gets to actual cost perspective of running this thing through the hospital. The fact is it was cheaper. Again, no one was making that argument, including the client. But, again, those are fights you can't have. I'd like to talk a little bit more about most favored nations if we can, Mel.
Yeah.
If we bring in MFN, we are importing wholesale a European price for a European market into U.S. healthcare and those government-funded asset classes, Medicare, Medicaid, et cetera. We're importing a European price. What will be the impact of importing wholesale a European price into the U.S. healthcare system? First off, do you think that's right? And secondly, what do you think is going to happen?
I don't know what's going to happen. I know it's, again, an underlying signal that the market-based pricing approach to drug pricing in the U.S. is being questioned. So I do know that. Many ex-U.S. countries use cost-effectiveness analysis to set prices as a rule, not a tool. I do not believe that is appropriate. And I say this as an economic modeler, not a decision maker. I know a ton about economic models and how they're built and their sensitivities and what they can do and what they can't do. I do not think the methods are robust or rigorous enough to be able to use as a rule to say this is the price. I think they're great to be used as a tool. I think we absolutely need to be having a conversation about impacts long term. But there's a lot of debates going on in cost effectiveness right now. We don't know if the societal perspective should be considered or not. We don't know if we should hold a drug's price constant for 62 years, like I talked about on the MS example, or if we should actually account for real world market dynamics and reduce the price after 14 years. All of those debates are happening, which to me just illustrates these can't be used as rules. This is information, not a rule setting mechanism. There's a difference between is paying for a drug at this price cost effective as compared to is this reward to the innovator optimal or appropriate for that price? Those are two different questions, but we make that the same in the conventional application of cost effectiveness analysis. You essentially build your cost effectiveness analysis, you hold your price constant, and then you back into okay, at what price would I meet this cost effectiveness threshold? Well, then that's assuming that the optimal reward to the innovator is that price. Well, let's look at GLP-1s. GLP-1s have already been priced far less than cost effectiveness thresholds. How big is the population for GLP-1s? Massive, right? Why would that have a same approach to coming up with the optimal reward for the innovator as a treatment for a rare disease that has 3,000 people globally? If you talk to an investor or a company, this makes no sense. The price per person would not be the same.
Okay, I'm going to now bash Quali, but that's fine. All right. In 2019, a report by the U.S. Government National Council on Disability, they found that Qualis for a Medicaid state plan, by definition, impacted the life expectancy caused by the underlying condition and were deemed discriminatory and violated the ADA. Now, there's not been a test case yet since then, but there's already case law that says, okay, this violates ADA. All right, fine. Do you agree with that Qualis potentially are going to discriminate against people with disabilities? What do we need to do to improve those models?
Health economic methodologists have already come up with alternatives to the QALY. So we have Chuck Phelps and Darius Lakdawala coming up with GRACE, or the Generalized Risk Adjusted Cost Effectiveness Analysis Health Outcome. I'm a big fan of that. I think it addresses a lot of these concerns. And I shouldn't even say concerns. These are major issues. So I think it addresses some of those major issues. There are other outcomes as well. I was part of the Equal Value Life Year that ICER uses. So that's interesting too, about assigning an equal quality of life weight and life extension. So I think there are some alternatives that are good. It again illustrates how important these are not to be used as rules. These are tools. This is information. Users of this information need to be knowledgeable enough about what it is saying and what it is not saying, what it can do and what it should not do. When I think of myself as a builder of these models, it's important to be transparent, to explain things. And there are a lot of wonky things that can happen in life extension. The quality and those conversations get at one of them. But I think it's important to think about what are we getting in this baseline survival period versus what are we getting in life extension? And we typically don't parse those out when we report out economic models. And I think we might see that more going on in the future. So people have moved on from the quality. They've realized like, hey, this was a not good thing. How do we address that issue, but still get this like generic summary measure that can be used across conditions? And so I applaud them for that.
I mean, the GRACE model is essentially you, based on unmet medical need and disease severity, you increase the willingness to pay threshold. So you basically alter the ratio on some level. Is that correct?
It's more complicated than that. And, it accounts for risk aversion, uncertainty, sure. And it can adjust like the utility and the threshold. So it is more complex than that, but it addresses that issue of lower quality of life to people with disabilities or things like that.
If you look at a rare cancer, and I will use acute lymphoblastic leukemia just because we've got a lot of experience modeling that, looking at hematopoietic stem cell transplant versus CAR T therapeutics, okay? A government came to us and said, look, we're trying to price CAR T. We do stem cells pretty cheaply. We think CAR Ts, for a couple $100,000, $300,000 versus what we're paying internally for a stem cell transplant doesn't make sense. Can you look at this? So we compared European hospitals to a couple US hospitals. Now, what did we find? When you looked at the activity-based cost accounting in a US hospital, pulling the data out of the actual treatment systems, the ICD codes, and then linking those up to individual HCPCS codes. Now, granted, that's Medicare, Medicaid, so it's going to be 70% lower. I get that, but it gives you a baseline. You get a delta. So if we do a stem cell transplant, what we're looking for is the difference in price, okay? We found about $200,000 in overheads for doing a stem cell transplant. That's an engine rebuild, essentially. You're ripping out the engine of a person. You're taking out their bone marrow. You're getting a transplant person. You're irradiating them. You're getting rid of the cancer. You're inserting somebody else's bone marrow. Hugely cost intense for the hospital, just in person power. There's a lot of people involved in that darn thing. In Europe, acute lymphoblastic leukemia, B-cell lymphoma, $25,000. Okay, well, what about all the overheads? Well, no, we pay $25,000. It's really easy to make something look cheap if you're only counting 10% of your costs. This is the problem I have with the quality assessment. It totally bypasses and ignores all of the actual overheads in the healthcare system. How do we deal with that? When you start looking at these things apples to apples, a lot of hospitals don't like CAR T, not because the treatment's not effective, because they see it a loss on their balance sheet, because they're billing $200,000 that they're now handing to a drug, which is actually more efficient. That's the problem I have with this.
I would say instead of that being an issue with quality, I would say that being an issue with how conventional cost effectiveness analysis is implemented by some players. I mean, yes. You could absolutely account for those overhead costs as your cost component, depending on what perspective you wanted. And so I think when we hear quality, we think of, okay, an incremental cost effectiveness ratio, an incremental cost versus an incremental quality, and it's applied this way, maybe in alignment with, like NICE's reference case or methods adaptation manual. Value is subjective. It's going to differ based on your perspective. You provided a great example of how that could differ based on the manufacturer or developer of the CAR T versus the hospital versus a US hospital versus a UK hospital. Like, value is subjective, full stop, period. You can let other people tell your value story, which they will, and they might be incentivized to do so in a more narrow lens. Or you can tell your value story in a way that you want to do it. I try to encourage people to think about the applications of CEA and quality-based analyses can be so much more broad than what is typically done if people actually do it.
But what do you do if the health system has an incentive to not look at the actual impact? What if politically it just makes a lot more sense to say, oh, we can do this for $25,000 or $50,000. This is too expensive, and they're not looking and they don't want to. I mean, that's a political problem. I'm sorry, medical doctors are often political actors. As government is more involved in our reimbursement system, I mean, you're going to get more politics involved in these decisions, and it's going to get further and further away from the economics. How do we square that circle, Mel?
Yeah, I don't know. That's pretty far. That's pretty far outside of my area. But I think it's a similar challenge of how do you get anybody to pay for something that you think is worth it? You say why it's worth it, and you use evidence to back it up.
But then that's a market decision again. And then we're saying we let the market play out. No, I think we need to have an informed decision.
Yes. Well, that's where I'm at. I think the market should play itself out. But can we use information to inform those conversations and have it rooted in something related to value? I mean, shouldn't a drug that enters the market that's safer and more effective than the competing agent, shouldn't a price premium over that be justified? Can't we use evidence to say, like, hey, this is what you're getting right now? You could be getting this with my product. I should be able to get a price premium for that.
But part of the problem is there's just no transparency in the system. I mean, these are black box negotiations. And for good reason. They're very competitive. And this is Doug Holtz-Eakin's position, the former head of the Congressional Budget Office, who runs the American Action Forum. Doug has been adamant that we need to open this up and just make the pricing transparent and the reimbursement transparent. We need to open up the PBM negotiation to transparency. I'm more and more akin to that mode of thinking. The more we could shed light on that, the better off everyone's going to be. Because right now, those are really difficult calculations.
I know for a modeler who has the drug price as an endpoint in every single one of her models, it is so hard to figure out what to plug in there.
It's really tough, particularly when you start looking at rebates and rebate modeling. We actually look at over 500 different indications and their prevalence to Medicare. That's an indication by indication weighted calculation that you have to do. And I think we're one of the few firms that is willing to invest overheads to do that. And it takes months. I mean, literally, it takes months, and that's proprietary intellectual property. And it's really hard to do. And I understand that a lot of people aren't going to have the assets and time to dedicate to that. Everything that's going on, where do you think we end up 3 to 5 years from now? Where are we at, Mel?
Net prices will be more transparent. And we will have a lot more biosimilars and generics than we do right now. You know, we're entering and have entered this massive patent cliff. Every one of us who loves this industry as much as you and I do, Duane, we've got to be talking about like, oh, wow, here are these drugs. They were priced high. Now let's look at what happens. Let's look at their prices fall off a cliff. And Fierce Pharma this week had an article come out about, the top 10 most anticipated generic biosimilar entry. That's exciting because generic and biosimilars, again, we talked about we want lower prices. Lower prices are great for everything, right? Like for economists, we like lower prices. Biosimilars and generics can give us that. But what it also gives us that I don't think we talk about is all those companies who had those products that now have generic or biosimilar entry coming in, they have to replace that lost revenue. And so what they do? They acquire more products, they develop new drugs. We as a society get more innovation. The things that we are so scared that our family is going to be impacted with today, hopefully the next generation or in a decade, whatever, how long it's going to take, they're not scared of those things. That's like how this innovation ecosystem keeps working. We have a high price, a high reward for the very rare few that make it to approval. And that incentivizes everyone else to try to enter that market. And then we have a time-limited period of time where, their time's up. Now generic and biosimilar copies can enter and drop down the price, and they have to develop new drugs. Like, it is a beautiful ecosystem. It's so exciting, and nobody talks about it.
Yeah, I share your optimism. I do think that there's going to be a lot of biosimilar approvals, and my fear is that a lot of companies are going to find themselves either moving to neurology or depression or cardiovascular, that's a younger target, or we're seeing VCs leave the marketplace or move to China because they're getting a better ROI. That's my concern. These are interesting times. The science is great. I'm hopeful we'll have more cures. And you know what? We should get together in 6 months or a year and have this debate again. I'll do your podcast.
Okay, yes,
you can ask me the questions. Melanie, Whittington, always a pleasure speaking to you, and I really thank you for your time, and I wish you all the best in the next couple of days.
Thank you.
The executive producer of the Vital Health Podcast is Duane Schulthess. Editing by Caden Drake. The Vital Health Podcast is a production of Vital Transformation, LLC, copyright 2026.